Good afternoon, everyone. Welcome to today's session. Before we begin, please do let me know if you can hear me clearly so that we can adjust accordingly before we begin with today's webinar. So at the bottom right of your session window, you'll see a chat area. Kindly type in there and drop me a comment. Let me know if you can hear me clearly. Great, I can see a couple of people can hear me clearly. So let's move on and begin. So today's session, my name is Kevin Hill from the National AIDS Control Council, your host for today's session. I am the program officer in charge of the research hub. I'm joined today by three presenters. I'll mention their names, but I will let them introduce themselves formally before we begin. Today's session is on accessing health services in East African community border areas, and we'll be looking at what we know. And this is in terms of, as you can see on your screens, the findings of the cross-border health services assessments. Great, so to begin, I'll let Boniface introduce himself, followed by Professor Olenja, and then finally Katherine. So Boniface, go ahead, let us know who you are and what organization you're from, maybe a bit about yourself. Hello, Boniface, if you can hear me. You can let me know in the comments section if there's a technical difficulty that we can address before we begin. There seems to be an issue with Boniface and his audio or his internet connection. Kindly allow me to sort that out so we can begin.
Hi, Kevin. Hello, Kevin.
Hello, I can hear you now.
Yes, I can hear you.
Great. So we were going to start with quick introductions. So, and you're first in line, so you can go ahead and introduce yourself. Tell us a bit about yourself and maybe your involvement in what we are talking about today.
Okay, thanks again, Kevin. I had actually started introducing myself. I don't know how, if everybody heard me, but my name is Boniface Kitungulu. I work for FHI 360 in the Nairobi office, working on the regional USAID project, cross-border health integrated partnership project. I work on research, and therefore I coordinated the studies that lead to the findings we're sharing today through this webinar.
Great, great. Thanks, Boniface. Professor Olenja.
Good afternoon. My name is Joyce Olenja. I work at the School of Public Health, University of Nairobi. I was engaged in the CB-HIPP project in the data collection and the writing of the report. Thank you.
Great, thanks. Go ahead, Katherine.
Greetings, everyone from Washington, D.C. My name is Katherine Brouhard, and I work for Associates. We were subcontractors on the HIPP project, and I look forward to telling you about our work today.
Great, thanks. So the order of today's session is we just did our introduction. So we're gonna go into an overview of what we're talking about today, and Boniface is gonna tell us about that. And then the next presentation is by Professor Olenja, and finally, Katherine will wrap that up. As we proceed with the session, you can type in your questions and comments in the chat box. And then we'll be having a question and answer session after the presentations, where we'll get to answer some of the questions that our audience for the day will be asking, and also elaborating on things that they will be interested in. So let's go right into the presentations for the day.
Thanks, Kevin, and thanks everybody for joining us today. We appreciate. This presentation is based on studies conducted through CB-HIPP project, which is a USAID AIDS project funded by USAID Kenya and East Africa. Basically, CB-HIPP is a regional project working in the East Africa region with the mandate to define, implement, and document, disseminate lessons on sustainable models for cross-border health services, looking at service delivery to meet needs of mobile and cross-border population and populations living around the border areas. So that is really the mandate of CB-HIPP, and based on this mandate of learning, the project designed in collaboration with the East Africa community and partner states, the studies considering the needs that the community as a region has moved quite ahead in terms of integration, with the free movement of people and goods having increased or increasing at a rapid rate. And this comes with the mobility, comes with the health issues in terms of the health situation in the region, people moving around and maybe needing services. But then looking at the region, there is limited information, data on mobility and health-seeking services, while looking at some key, or generally some key health indicators, you will find that some of the border areas have poorer health outcomes, just like you may be able to see from this map at the time you see it, which is an illustration from the Lake Victoria region, showing movement of people and HIV/AIDS prevalence around the districts or counties around the lake compared to the national. For example, Kenya having 4.9% at the time of developing this, while the counties at the border, like Migori, which I think you can see here, it's at 13%, and it reflects, if you look at Rorya, at 6.9% compared to Tanzania, which is 4.5. So considering lack of data and considering the poor health indicators at the border compared to the national averages, the project designed these assessments, which were led by FHI with the health financing aspect of it implemented by APT Associate, and that will come at the end. So for this part of the presentation, which I will introduce the methodologies we've used and that, and then Professor Olenja will share the findings. We'll focus on that, and Katherine will focus, including methodology and everything, on the health financing aspect of it. The studies, both actual health financing and the baseline information, were conducted in the 5 EAC countries at 8 cross-border sites that you can see from here. Some wet border sites, specifically on Lake Victoria and Lake Kivu and Lake Tanganyika, and then the land border areas that you can see from this slide. In terms of the area of focus, it wasn't the entire district, or rather the project covers an area around the border up to 10 kilometers from the transport corridor, assuming this transport corridor, 10 kilometers along the transport corridor and 5 kilometers along the border. So populations that are around that diamond is really what the focus was for what we are calling the land border areas. And for the wet border areas, which is sites on the lake side, the focus was on fishing, beach landing sites, and the islands around that area. This is an example using Kenya-Uganda border, this Port Victoria, which is a landing site for fish and seaport, and then the areas around Uganda going into the islands in Uganda. So data collection and the study itself focused on these areas for each site. The baseline and formative assessment were designed in a participatory process involving the EAC Secretariat and partner state experts, and also CB-HIPP's implementing partners, CB-HIPP's partners. All of them together, they designed and developed the protocol and the tools that led to the implementation of this study. The studies were approved in each of the 5 countries by respective local institutional review boards, the research ethics committees, and the PHSC of FHI to meet the USG research requirements. The studies were conducted in a phased approach between December 2015 and August 2018 in these 8 cross-border sites. The timing was really determined by each country's approval process and time, and the authorization processes in each of the countries. But the data was collected between December and August 2017 at different sites. The findings you're going to share now are based on quantitative and qualitative methodology, which from here we have about 9,000 people generally in the region that were interviewed, and the populations that we focused on cross-border and populations living around the border areas, but we looked at specific population categories, including female sex workers, MSM, people who inject drugs, and fisherfolk, long-distance truck drivers, vulnerable women and girls, we could call adolescent girls and women. And then we also interviewed PLHIV and also healthcare workers for the quantitative part. Then the qualitative, using FGDs, the same groups of people, we had FGDs, IDIs, and came from our interviews. The analysis really is based on country-specific, so we've provided the samples for each country here. I will let Professor Olenja share the findings that came from these, from selected indicators.
Yes, thank you, Boniface. I'll share the findings. This is really a snapshot of what we found out. The details are available in the reports. And the focus was basically again on mobility, and we find that the high levels of cross-border mobility reported among the key and priority populations. If you can see, MSM is really over 80%. This movement either way. In Uganda is where we find that persons with who injected drugs is almost close to 100%. So we are using the two countries, Kenya and Uganda, just to illustrate this. But although we did research in the 5 countries, but because of the timing in terms of data collection, the Kenyan data and Uganda is much more comparable than the other countries. But there is data available for each of the countries. So this is really a summative diagram that illustrates the issue around mobility, the mobility dynamics, and the various reasons that contribute to mobility of the population. And there is a clear relation between the mobility drivers, what are the drivers for this population being mobile, and also the mobility patterns, and the attendant vulnerability and risks that we observe in these populations. So for example, in terms of mobility patterns, we found that the movements were on a daily, weekly, monthly, or seasonal basis, depending on the nature of the population. An example could also be, for example, the long-distance truck drivers. They are crisscrossing the borders, whether it is on the Ugandan side, Rwanda side, or Tanzanian side. And in terms of the mobility drivers, there were various reasons around economic, the family interactions, and more importantly, seeking services, and where we think of, in some cases there could be security concerns. With this mobility, we have the attendant vulnerability, and that could be around gender and power dynamics. For example, with the categories of the police, such as the female sex workers or vulnerable girls and women, whereas for truck drivers, as an example, their vulnerability would come around them being exposed to HIV just because of their nature of movement. The issues around stigma and discrimination, abuse and violence are really accounting for them. Populations such as the female sex workers and vulnerable women and girls. The risks that come with it, of course, is the issues around multiple and concurrent partnerships, transactional sex, particularly between the female sex workers and the long-distance truck drivers and the MSMs. So when put in a nutshell, you find that this idea of having to put the relation between mobility and the mobility patterns and risks and vulnerability all relate to the needs of the populations and also their need to seek care or health services in the different countries. This is just an illustration of the mobility dynamics. Is to show that there is a high degree of mobility reported among, for example, female sex workers, with Tanzania recording about 83%, Uganda 67%, Kenya 60%. These are people who have traveled outside their own countries in search of sex work. This data was collected in the asking about whether they have traveled out in the last 6 months prior to the study. And some of the quotations really are illustrative of the various populations. For example, female sex workers indicating that they do move in response to where resources in terms of money can be found. So they'll move between Uganda or Tanzania or Kenya, where they can actually be able to raise money or an income through sex work. Looking at Rwanda, we find it's similarly the same, that MSMs are also moving between Rwanda and Uganda and as far as Kenya, but basically looking for an income. And these movements, we find are as frequent as can be within the last 12 months as we did design the study. So with these movements, one of our interests was also to find out what are the challenges from the populations. And the main challenge reported by the target population is accessing transnational health services. As they move and they stay for a period of time in either country or either side of the border, they also have needs, and one of the needs is really one for health services. And we also note that different mobile populations have different challenges. So, for example, when we look across, the challenges around time, stigma, and distance, cost, and fear are really highlighted by these populations. And time was much more significant for, let's say, truck drivers who are really passing through, maybe being on either side of the border 2 or 3 days. Because of the distance that they have to cover, they don't have much time to access services as they pass through, yet they have a need for it. Stigma was a key factor among female sex workers and women and vulnerable girls, as well as persons living with the HIV. The other one, of course, is distance, and cost is a major challenge, and this will be discussed much more in the next part of the presentation. Still, some of the challenges with the cross-border care, we'll see that from the discussions of through the focus group discussions, mobility disrupts access, and that much was accounted for by long-distance truck drivers and any of the other groups that would move, because when they get to the other side of the border, they may not be eligible for those services, given the fact that they have really just crossed the border. And we'll talk a little more about that when we talk about the policy gaps. Stigma leads to high defaulter rates due to cost of seeking services far. We mentioned the female sex workers who may actually cross the border just to be able to avoid being stigmatized or discriminated against. And in the process, because of the distance, the time it takes, and the cost it takes to actually move, then you find that the defaulting is one of the key areas, for example, particularly for HIV and for HIV services. Costs, again, we mentioned availability of the services, and we mentioned that when we are talking about what is really at the health facilities. In one instance, language barrier was actually mentioned, particularly in Uganda, where Kiswahili may not be one of the key languages, and therefore Kenyans who are seeking care in Uganda, unless they know Kiganda then and know English, then they have an issue, they have a challenge in terms of language. Lack of drugs or different treatment regimens was a key area that was mentioned by the populations. We also were interested in the provider perspectives on the people that they serve. And one of the main challenges was really one of adherence and follow-up, particularly in Kenya, that came out as top for the 18 service providers who are interviewed. 17 actually noted that adherence and follow-up is a major challenge. Stigma is common in the two countries, though it comes out fast in Uganda. So adherence and stigma are really key issues, but we can also look at the lack of time, and we mentioned particularly for long distance truck drivers, time is a major issue. For some reason, adherence and follow-up wasn't too much of an issue in Uganda. But basically, adherence, stigma, lack of time was one of the issues that was mentioned by the service providers. In terms of the interviews of key informants, it came out that though there's no specific policy on mobile and cross-border key and priority population services, existing policies were not discriminatory in the sense that when you look at, for example, in the Kenyan case, the Constitution really provides for service provision to all population regardless of religion or sexual orientation. So from the key informants, both in Kenya and Uganda, the national policies are clear that all clients are treated equally and do not distinguish between specific groups. But when it came to actual discussions with service providers, the fact that there isn't a specific reference to key population and priority populations, these populations sometimes will fall in between the cracks in terms of service provision. And one of the other challenges, again, was from the facility assessments, was really looking at the supplies and readiness of these facilities to be able to meet the needs of the various population groups that will go through their facilities. And in terms of the healthcare system, we find that lack of data on mobile and cross-border key and priority populations did impede planning of services within these health facilities. Additionally, stock has attributed to unplanned clients accessing the services because it wasn't too clear what are the numbers, what therefore should we plan for. So when you look at some of the data that was collected from the 39 health facilities in Kenya and 23 facilities in Uganda, you'll find that quite a number were reporting stockouts, for example, of HIV kits and also other commodities. Looking at the FP stock or stock out on the day of the assessment, you find that quite a sizable number of the facilities reported that they didn't have condoms, both female and male, they didn't have pills, and all the other set of FP commodities. And this is just really to tell us that many of the facilities were not really ready to provide services to many of these population that went through their health facility, both local and those ones who are cross-border. When we look at the cross-border referrals and treatment of patients, we note that over 90% of service providers, both in Kenya and Uganda, did report to treat patients from outside the country. And that just goes to confirm that there's a lot of movement between the countries. And this, although they do treat over 90, though over 90% of the service providers reported treating clients from other countries, we know that there was no formal mechanism to really govern this. For example, 31% of Kenyan facilities and 30 of Uganda report they make cross-border referrals. So there is a lot of activity in terms of service provision with the cross-border communities. When we did interview the clients of the various groups, whether they're female sex workers, people living with HIV, we also note that between 6 to 26% report accessing services across the border. So again, to confirm that people move in between the borders to access services. And some of the reasons that we gathered that the people seek services across the border, the different population groups, would be quality of care really came out as one of the main reasons. So that if you interviewed populations across the border in Kenya and Uganda, in some way they would say that we'd rather we go to Kenya for services because of the quality of care. If it is between the boundary between the border between Kenya and Tanzania, they'd also make reference to quality of service. I recall clearly women in Kenya, in Tanzania, reporting that they seek care for maternal health services in Kenya because of the free maternity services. Proximity, of course, is also key for most of the populations. And the other one would be attitude of service providers. And that is why attitude of service providers goes together with the quality of services. A key area of our investigation was really looking at the policy environment, and we did note that there are policy gaps, particularly from the discussions with key informants within the ministries of health at the county level. Those are the counties that really border that are along the border. And one of the key areas was the lack of policy guidelines on transnational access to health services, and that the current systems do not support defaulter tracing for individuals on treatment across the border. And this would then also contribute to loss to follow-up and on achievement of the 90 global HIV targets and other treatment goals. In addition, the current tools do not document data on migrant populations. So treatment does go on at the border, at the border posts. But because of this lack of policy support, then there was much that wasn't available. And one of the key informants at the national level would say there's no specific indicator that captures data for migrant populations. So that becomes a huge challenge in terms of planning. And an example was given of Busia, the health facility, where the ARH coverage is over 100%, but that also means that part of the coverage really is the population largely from Uganda. Yet the planning for Busia County would really be based on resources for Busia County as a county in Kenya, without taking into account the fact that there is this population that comes through. So we really want to conclude by saying that transnational access to health services is a critical component for quality of care among mobile and cross-border key and priority populations. And this is really based on the data that shows this amount of movement across the borders for the different populations that would need health services. So access to health service influenced by proximity, perceived quality of services, the issues of cost, stigma and discrimination, of course, plays a very key role, and much more importantly, the policy environment, which would be respective of our nationality. Mobility dynamics in the region vary but affect access to health services and therefore the health outcomes. We are, the results really pointed to the fact that there's a need for targeted interventions which are sensitive to mobility, so as we are able to increase access and uptake of health services to meet the 90 global HIV targets and other treatment goals within the region. And also the need for sensitization of service providers, including community health volunteers, on migration health and their specific needs to enhance their skills and raise level of comfort to deliver services to mobile and cross-border key and priority populations. We also note throughout the research process that there's a depth of data on transnational access to health service between the neighboring countries and regionally. And this really calls for the need for regional research rather than, just country-specific research because of the interconnectedness of these countries. There's therefore the need to harmonize research policies to enhance regional research to make comparable data available and to inform design and implementation of intervention for mobile and cross-border populations. As we started off, I said that we have used much of the data for Uganda and Kenya, and this is because these two countries, in terms of data, in terms of research clearance, we did get ethical approval just about the same time. So we did the training at the same time and collected data, similar data. For the other country, there was a few modifications here and there. But for here, really, we are pushing for the fact that if you did harmonize research in the region in terms of policies, then you'll be able to collect data that is comparable in real time. And the need, as a follow-up, there is the need to harmonize or call for harmonization of and research authorization process to enhance regional research. And this is based on the fact that this region really faces similar health problems. Joint review of research protocols to facilitate timely research and comparable data across the neighboring countries. Finally, the really harmonized tools and standard operating procedures for referral and tracking of patients across the borders. We have also, through the presentation, we've also noted that there was no standardized tool for data collection that will be shared across the regions. Healthcare workers to share data and information to strengthen service delivery for target population. This is so important, and it would also help in the follow-up of the clients. I think this should really be the end of this part of the presentation. The acknowledgements for the region, the involvement, the ESC, and the various countries, USAID, the FHI 360, and mostly the field teams and study participants around the region.
Yes, just before Katherine came in, just to highlight what Professor said, this studies, including even the findings that Katherine will be sharing shortly, involve several people who are mentioned here, and many, of course, not mentioned individuals, but basically these institutions that were represented in having this successful.
Great, thank you. Thank you very much, Professor Olenja, for all this information. I believe I've seen a couple of questions coming in. We will be handling these after Katherine's presentation. So we're just going to get right into Catherine's presentation. Let me just load this up. There we go. So Katherine, please take it away. Let's see. It appears we may have lost Katherine for a bit. Let me just see if I can get in touch with her so we can run through her presentation as well.
Can you hear me?
Oh, there you are. We can hear you.
Yeah, how is the echo now? Is it better?
This is way much better. There's no echo, but
Okay.
in case any of the participants have an echo, we'll be able to advise. But so far, so good.
I don't see the presentation up yet.
Let me see. Is it up now?
No. I don't know if others can see it. I have a hard copy, so if everybody else can see it, I can go through my hard copy and tell you to advance.
Yes, it appears they can see the presentation. There's someone experiencing an echo, so let me just clear that up and then we can begin.
Okay, just let me know when to start.
Great, sure thing. So I believe we can proceed. Boniface was having a bit of trouble with an echo. Just waiting on a response from him on whether, yes, he says it's okay on his end. So I think we can go ahead with this presentation.
Okay. So, assuming we're on the first slide, because I can't see the slides, thank you all for joining today. Again, my name is Katherine Brouhard, and I am a program manager at Apt Associates in the U.S. So I helped manage Apt's work on the CB-HIPP project for the full term of the 5-year project. My colleague Agnes was really the brains behind what you're about to see. She was in Kenya and running and implementing the studies we're about to talk about. Next slide. So in this, I just really wanted to highlight, and I think that the previous presentation really nicely highlighted the fact that there's really several dimensions we need to think about in terms of expanding access to high quality health services to a greater population, and also ensuring, and the sort of the piece that I'm really going to focus in on is ensuring that that can be done without having those populations face great financial hardship. Next slide. So as Boniface said, APP's role on this project was really to look at health financing options for cross-border and mobile vulnerable populations. So if you see sort of our function, our role was really to look at, is there a way to finance sustainably a healthcare product that would be portable and affordable. So portable obviously means somebody in Kenya could go and access services in Uganda, and that this product would cover those services. So we looked at, we thought about health insurance and we thought about savings plans. And my presentation is really going to focus in on the health insurance piece. And I'm not going to talk about it today, but we also, in order to sort of hone in on what would be, again, portable, affordable, and sustainable, we looked at the regulatory landscape across the EAC. We looked at the financial capacity of facilities, and we looked at the cost of services. And then finally, we did an ability and willingness to pay survey. And that's really what I'm going to focus on. Next slide. So this just quickly shows the locations where we did the ability and willingness to pay survey. You've already seen a larger version of this from the previous presentation. Next slide. So the ability and willingness to pay study focused on in Kenya, Uganda, Tanzania, and Rwanda. The study collected data through structured individual surveys. So we asked respondents about their demographic and economic characteristics. We asked about their health-seeking behavior. We asked about their health financing behaviors. Do they have insurance? Do they save for insurance, et cetera? And we asked about their use of financial services in general. So savings, banking, et cetera. We did 880 household interviews, and we did 963 MVP interviews. And MVP in this case are long-distance truck drivers, fisher folk, and clearing and forwarding agents. Next slide. So what we found is that the clearing and forwarding agents and the truckers had the highest average wage, level of income, and that the average income in Kenya, the average income was the highest in Kenya and the lowest in Uganda. Next slide. So we'll spend a tiny bit more time here. You got a taste for this on the last presentation where we showed that that cost was a significant factor in mobile vulnerable populations not seeking out health care in other countries, I believe. Boniface can correct me if I was wrong on that, but and I think that bears out in what we found in our study, and you can see here that for the clearing and porting agents, the truckers, the fisher folk, out of pocket was the most common method of paying for services on work travel, which really highlights the fact that there's not really a sort of financing product that is available for use when these populations are traveling in other countries. So we saw that just 23% of movable vulnerable populations had health insurance. Only 17% reported that it was portable, and 38% of mobile vulnerable populations reported foregoing health care due to lack of money to pay for it. Next slide. So, as a part of this survey, we wanted to find out what the willingness to pay for health insurance was. And so what we did was we told people, respondents, about the EAC minimum package. And the minimum package covers basic services. HIV, family planning, etc. It's a pretty basic package, and what we did was we described the package, and then we said, would you be willing to pay $6.70 US cents? I'm sure we converted that for this to be able to access this package, and as part of a health insurance. And so that $6 would be the premium on this health insurance product. And what you see here is that $6 is the mid-premium. That's what's in the middle here. So just 28% of households were willing to pay that in order to access that theoretical health insurance benefit. And that was for 3 months of coverage. And that the clearing and porting agents, the fisher folk, and the truckers, about half were willing to pay that $6. And then what you see for the lowest premium, for those that said, no, I would not be willing to pay $6, we asked, what would they be willing to pay at a lower level? For those that were willing to pay that premium, we asked if they would be willing to pay more. And so the higher premium you see there is $9 for 3 months of coverage. Next slide. So what this really tells us is that the willingness to pay for a basic health insurance product is really quite low. As we saw, just 28% of households were willing to pay for this basic health insurance product, which would be portable across borders. And that just 50% of fisher folk, truckers, and clearing and forwarding agents would similarly be willing to pay about $6 for 3 months of coverage for a portable benefit package. So this just tells us about if we wanted to create such a package, the premium would have to be really very low in order to make that financially sustainable. And of course, the other piece of that is that you would really need quite a large pool of areas of people buying into the product in order to make it financially sustainable. Next slide. So then what we did with this information is we did an actuarial analysis. And an actuarial analysis brought together the data we had collected, both with this study, with the costing study, which we also did, which I didn't go into here. And it really brought together various data sources to tell us, for this basic benefit package, what would a premium have to be in order for it to be financially sustainable? So how much would individuals and households have to pay in order to make this product, a health insurance product, feasible? So if you go to the next slide. So in order to put a price on this portable benefit package, we used our pay study data, and again, the cost study from the CB-HIPP, again, this EAC basic benefit package includes things like HIV testing, antiretroviral treatment, TB, family planning services, screening services, sort of among others. You need a certain amount of data about sort of current health insurance in order to do this kind of analysis. So we modeled our costs on Kenya's National Hospital Insurance Fund, mostly because the NHIF has a relatively large membership, and the amount of publicly available information lets us take that data and sort of model information about our theoretical health insurance product. We assume this benefit would be available to cross-border populations in Busia, Migora, and Taveta, Kenya, as a rider to the national, to the NHIF. So a rider would be, an individual is an NHIF member, and then they choose to buy into additional benefits, and that's what a rider is. So we assumed that this rider would be available to cross-border populations. And since we were using the NHIF as our basis, we limited that to the cross-border populations in Kenya. And then we further estimated the pricing, again, based on the households and normal populations living in those areas. So if you go to the next slide. What we found is that once we did all this analysis and did this modeling, what we really found is that the portable benefit package, sort of as we were conceiving of it as a project, as a benefit package that would be sort of modeled on, focused on, and made available to cross-border populations, is really likely to be unaffordable if it's only offered to that cross-border population. So what we did, and as we said, if we have a standalone rider, like I said, as sort of additional benefit that NHIF members would buy into, that the price per person per year would be $13. The price per household per year would be $58. And if you're doing your math, what we saw before, so this, the willingness to pay, we said that these percentages across these populations, 28% per household, would be willing to pay $6 for every 3 months. So then you say, oh, well, you multiply that and they're willing to pay, this per year. This $54 per household per year and is actually a 90% increase to the current monthly premium. So the current monthly premium for the NHIF is $5 US. So this would really be a pretty significant additional cost for this package. And then you sort of have the issue of making sure enough people buy into it, et cetera. So we really think that as a standalone product, focusing just on this cross-border population, that given the willingness to pay, given the low income, a standalone product is probably not feasible in our modeling. Then what we did was we said, okay, what if the NHIF made this benefit available to their entire membership and they made it mandatory? So it would simply be an expansion of current benefits. If we added a portability factor to it, if every single member of Kenya's NHIF was able to go to Uganda, for example, and access services there and be able to charge that, and have their insurance cover that. And that is much, much lower. As you can see, it's just 11 cents per person per year, or 44 cents per household of 4 per year. And so what we take away from this is that if we really want to expand access and coverage for these cross-border populations so that they can access health insurance, where they are as they travel, as they sort of live their lives across borders, that the benefit would really have to have a much greater pool, that the benefit would really have to be available in this case to the entire population covered by the NHIF, which is I think significant just to know that would be sort of a difficult. It would be difficult to design a health financing product just focusing on those cross-border populations. So if you go to the next slide, so I just wanted to bring us back to sort of the big picture of what we're trying to do, and what we're sort of all focusing on, which is making health services more widely available to these cross-border populations, to make sure that they can get the care that they need where they are. And sort of from our health financing, just looking at the cost and the ability to pay for this, we would really, what we found is that specifically a health insurance product would really have to be more broad-based than covering just the cross-border population. Thank you for your attention. That concludes my presentation.
Great, thank you, Katherine. Based on that conclusion, I'm guessing we're not going to be looking at the additional slides. I can see we had slide 16 all the way to 21.
Yeah, so I included those extra slides if people have questions about the organization of health systems across partner states. I have a slide on donor funding, cost of mortality, the essential benefit package, and demographics from the willingness to pay survey. So I just included those in case people have specific questions, but I wasn't going to dive into them.
Okay, then with that, I guess we can jump straight into looking at the questions that a couple of people asked. First one, Jacob asked, rather mentioned that the text, and I think this is in reference to the presentation made by Boniface and Professor Olenja. He says the text here is reading traveled outside the home district and not home country. Could you clarify that? I don't know, maybe Jacob could tell us what that was referring to specifically. Maybe we can get back to that after he clarifies that. Daniel says, I wonder whether MSM can be distinguished from MSW, as the presentation indicated male sex worker travel to other countries and regions for the purposes indicated in the presentation. I think this is in reference to Professor Olenja's presentation.
Yeah, can I?
Yes, sure, go ahead.
Yeah, thanks, Daniel, and thanks, Kenny. I think, Daniel, we've made reference to MSM throughout the document, but not to MSW. So I'm not sure if that was from the speaking, but yes, correct. We are not distinguishing between MSM and MSW.
Vincent Atitwa was asking whether lack of drugs is a challenge to travelers only or even people at home.
Yeah, this clearly, as Tito correctly says, it should be a challenge to everybody. But then the challenge under this, when it comes to people who are mobile, comes with, there were mentions of differences in regimen, where somebody comes from Uganda to Kenya or Kenya to Tanzania, and then the regimen that the person is on is different. And again, this is context specific and disease specific. We may not be able to go into details now because some of the regimens are not necessarily different at the moment. But in terms of reported, people mentioned having gone to a facility, but the regimen that they were on was not being offered in the other country. So that's where it comes to the drugs. The challenge with drugs becomes not just an issue of being available, but an issue that the drug that person requires is not what is there, but drugs are available for the population.
Okay.
I don't know if that.
Let me just jump right back to the question by Jacob. He had asked, he had mentioned that the text was reading traveled outside their home district and not their home country. Please clarify. And Jacob says that this was in one of Professor Olenja's presentations on percentages of people or population seeking health services across borders. Okay, I think that's also a question we can get back to.
Can I just respond to that?
Molel asks whether there was any exclusive, was there any exclusive driver for Tanzania sex workers at 80%?
In terms of, that was in terms of movement?
Yes, sex workers in Tanzania were 83% reported movement. And when you go into the discussions, particularly focused, I mean, these were in the interviews with the sex workers, really no specific reasons that distinguish Tanzania and the other places, but there's the same factors, people saying that they move for purposes of income, where depending on where there is a market for them, that they move. And when it comes to, when they are asked how often you move out of your district to another district, how often you move, or across the border, Tanzanian sex workers seem to have a higher percentage of 83. So, but the reasons are not very different. Just like, I mean, we move because that's where there's market. And I think Professor had given an example where somebody described in the quotation movement, but it was based on Kenya. Somebody moving from one town in Kenya where Mias, in those days when Mias was still active, no? People would go to Mias when these farmers are getting paid, and they would move to Narok when wheat farmers are being paid. They would move to Kericho when tea farmers are being paid. So that is one of the movements that was described, and I wouldn't pick anything specific different from Tanzania. And when it comes to the question on movement to district, is it district or cross-border? We define mobility, and sorry, we didn't give this definition. We define mobility not just between cross-border, but also people moving from one district to another district and seeking services in those districts and counties for Kenya. So the question that was asked on that, really, yes, those movement between districts that we define as mobility.
So is that to say, was this something that you specifically aimed at looking at? And by that I mean movement, for example, between counties and districts, or is this something that came up while you were looking at the movement happening between neighboring countries?
It was in the design to get to know internal mobility as well as the external mobility. So in the process, we found, yes, there's movement. And if you saw Professor's slide on the diagram that talked about the differences in movement, even talked about weekly, daily, monthly, and those kind of periods. Yes, we decided to ask the question, is there movement, internal movement, which is defined by districts and counties?
And maybe just to add up on that, that even within internally, the internal movements, if you talk to female sex workers, if they've moved from Busia and in Mombasa, they will also be struggling to access services just because that's where they don't come from there. And they were talking about that in relation to even NHIF, that even when you have an NHIF card, there are certain designated places that you need to access your services. So yes, even mobility within the country has challenges that we need to look into.
This is part of a series of questions that I've seen. A couple of people have asked whether the data can be shared. Other people have also asked whether the slides can be shared. With the permission of the presenters, I could share the slides after this session is complete. So I'll be able to find that out and advise accordingly. Angela Oket says that she's interested on the data whereby women in Uganda are crossing to Kenya to get free maternal services. Any comments on that?
Yes, there is some data in terms of people reporting reasons for movement, and even between Kenya and Tanzania, and people moving to Kenya when particularly maternal services became free, and people move across borders for different reasons. There are those who will come to Kenya for free maternal services, and there are those who will go to Tanzania, for example, or Uganda for that matter, for another service. Yes, that is there in terms of what we reported. But when it comes to volumes and numbers, that would require somebody looking at the service statistics in the facilities. And one of the challenges that I think Professor mentioned was the fact that the systems within the countries don't record nationality and mobility. That's where the challenge was for us reviewing data to see if we can tell what are the volumes we're talking about for accessing these services. People don't necessarily say therefore the system doesn't collect that information because of many different reasons. So just for our data, what people say, yes, there's some data around that, but when it comes to what the volumes are like within the facilities, because of the HMIS and the tools that exist, that is a challenge for us to get.
Lucy Gatti is interested in data more specific to the Isibania border when it comes to Tanzanian people crossing over for healthcare services into Kenya, or vice versa, that is Kenyans crossing over into Tanzania. specifically through this border point. I don't know if there's data available for that.
Yeah, for this particular border, this was not included. If you look at the sites that we collected, the data that we shared today, there was within Isabani was not one of them. However, we conducted a different assessment whose results have not been shared in this forum on TB and TB-HIV services, where Isabania was one Isabania Sigare were included. So when it comes to movement and health-seeking behavior on TB-HIV, we have some data based on a different assessment, which of course we are happy to provide information on what we found out. But again, just to say, when it comes to service statistics and what exists, that data doesn't exist anywhere that we came across.
Daniel says, I presume policy guidelines refer to national level policies. Do we have any similarities in the way service provision, according to these national policies, should be made in the 5 countries under review?
Okay, we made reference to policy guidelines. These are, yes, you're right, the national level policies which refer really to specific countries. And that is why we are talking about harmonization of those policies at the regional level. And that's when we'll get, a way of also harmonizing the provision of the services. But as it is, I think much of it was service provision based on national level policies for each of the countries. And I think that's where we find the gap to be, and also the opportunity to be able to harmonize the policies through discussions, of course, within the 5 countries.
Great, thanks, Prof. I think that was also a question that I personally was going to ask, whether the project captures recommendations that can be pushed to maybe governments and policymakers across the countries that were involved, just to try and standardize parts of these policy documents across the countries to enable easier portability of these health services. So I think that answers that. Let's look at another question.
Yeah. Do you want to say something about that?
Yes, sure. Go ahead. Definitely.
Yes, just in addition to what Prof was saying, just to mention, yes, if you look at even the slides we have very specific recommendations around that, and in the reports also we have that, and building on these findings and recommendations we have, CB-HIPP has an extension for 1 year. Actually, the project is serving an extension period, and one of the issues that is in the current extension is advocacy and lobbying and working with the EAC and partner states on that aspect. So the project is doing something around it, which of course we are happy to share the progress as the discussions around it go.
That sounds good. So that sounds like, within the next year, these discussions should be kicking off. That's great info.
Yes, just with the caveat, not promising that policy will be out. Of course, policy process.
Very true, very true. Ochieng was looking forward to seeing any data on the findings about fisher folk. I would like to assume that he is alluding to, maybe deeper extracts of the data that may have been found. Maybe this will be found in the full report.
Mm-hmm. Correct. Which we will share with you, Kevin.
Great. And so I should be able to also share the same with today's participants, right?
Yes.
Great, thank you. Let me see. There's a question here by Caleb. He says the main issues of medication is lack of drugs at our public health facilities. How can this be improved, mostly for insurance people?
Yeah, this seems to get into a different level, not necessarily based on the data. Yes, computer, drugs is a challenge, but in terms of recommendation and based on insurance, I would like I would like to say, yeah, I don't know if Catherine, you have anything to say about this, but true, that is a reality, and there are areas that there's one thing that I know that has been a discussion around is it called pool? The region coming together to get drugs more cheaply if they are purchasing as a region. I know those discussions have been there within the EAC, and I'm just being careful not to speak about it because I'm not an authority on that, and I may not speak for EAC, but somebody may want to look at what discussions are going on about pooling. Is it pooling?
Hilda has a recommendation here. She says maybe we can address some of the policy gaps on transnational access to health services by addressing them in the EAC HIV law, in addition to addressing them in national policies. She says that addressing some of these laws would be a good place to start.
We agree.
Maybe a couple of questions from my end, just to look at this at a more general level. When you are doing this project, what did it take to receive ethical approval? And this is just for maybe the researchers who are joining us today. What did it take to receive ethical approval across all these different countries? Was it difficult? Maybe you can tell us how long it took and what it took.
Yeah, we.
Okay, you start off, I think.
Yes, and I think Prof talked about it, and you notice that this study took us like 2 years between December 15 and December 2017, and one reason is really because of the differences in terms of how long it takes to get approval from one country to the other. There are places where we got within 6 months. There are places where it took more than a year to get approval, and the problem also comes to having a generic protocol with the different requirements and different reviewers asking for different things. Then you need to make changes to suit one country and the other, and you've already received approval from one country. So when you make changes based on the other country, then you don't know if you have to go back and change in the other protocol. So based on that, and I think Professor Olenja mentioned the differences in terms of some of the questions that were missing, because in one place it had been approved and the questions were included. In another country, that question was vetoed and we had to change something. So if we were to include the question or remove it, then you had to go to the other country's IRB. So the back and forth and the differences in requirements and processes definitely is an issue of concern. And I know East Africa Health Research Commission is mandated on this area, and they are working around it. How far they are, I wouldn't speak to that.
I see, and I think I've heard about that discussion. I think it would be helpful if there was maybe a common ethical review committee across the East African community. I think that would make approvals quicker, based on the fact that they'll approve for several countries at the same time.
Right. Just before we go, to mention that CB-HIPP has been working with EHRC on this particular area, by the way, as much as I said that they're working on it, CB-HIPP has made contributions from this assessment to provide information for EHRC in terms of their processes around looking at that area.
Great. I have another question, probably a final question for the day, if we don't have more questions coming in from our audience. And this is a question for Katherine. Maybe in your experience, are there any other portable insurance products that we could learn from?
That is an excellent question. I'm honestly not sure. We did not, with the sort of data that we had, under CB-HIPP, we were able to look specifically at this health insurance question. To the best of my knowledge, a health savings product would not necessarily wouldn't be limited by accessing services in a different country. So that would be sort of portable, given that it's a more sort of personalized product. To the best of my knowledge, and I will say that I believe that the NHIF has a portable benefit, but it's mostly for sort of very high-level care that isn't available in Kenya. So it's not the sort of basic level of care that we're talking about here. And I think that kind of service is available, but again, it's not covering, it's not the kind of care that this population is really looking for. So to the best of my knowledge, there is not a product out there of the type that we're describing here.
Okay, I see. So I guess this would involve, a bit more research and then, coming up with a product that works for specific regions, not just our East African community region, but then generally in other regions as well. I guess it would involve customizing products that fit those populations based on the data that you'd have seen on the ground.
Mm-hmm. Yeah, and I think that there's a little more research to be done, but mostly I think that there's a level of buy-in that would be needed to move forward and to test out this kind of product to see if it would really work.
Great, thank you. Maybe the only thing I'd want to say maybe in closing before we end this session is I think since especially something like quality of service is a factor, I think it's important to have this information, have these results cascaded down maybe all the way to facility level, where it can help improve the various services that are offered, just to bring them all up to the same level and to ease access by the various populations, because I did notice that various populations have different reasons as to why they would travel across borders to access services.
Yes, correct. And CB-HIPP is using all available forum, and thanks to Mark and thank you, Kevin, for the opportunity for us to share this. And we have much more data, I've mentioned the TB data, and more information around mobility that we have to share to the other forum. But yes, we are working with the counties for Kenya and the districts in respective countries to get this information to the lowest level possible up to the facility level, and then packaging it for that purpose.
That's great to hear. I don't know if you have any remarks in closing just before we end the session.
Yeah, I don't know if Katherine has, but maybe for me, just like I've already said, is to thank everybody who joined us and participated in this, and thank NAC greatly for the platform. It's a great platform, and as a project, we have a bit of data. I mean, we have a lot of data, let me say, that we've collected, but that doesn't mean that we've covered everything that should be covered. There is still a lot of need for in-depth understanding and research around the issues that we have identified through these exploratory studies. Somebody to look at them a little more keenly. I know even in terms of cost, what Katherine has shared, and looking at what you shared in terms of people saying that cost is a factor that is affecting their access to services, particularly in their movement. And I think Prof also mentioned in terms of portability of even energized women within the country to a different district. Just a good understanding of what can be done for populations to access services easily, and also in the region there are best practices. I know about the community insurance in Rwanda, which people can learn from, and the NHIF in Kenya. Basically, opportunities for people to learn from what's happening in the region are good, and platforms like what NAC is providing, if it can reach beyond borders, is helpful. So just to say thank you again.
You're very much welcome. Professor Olenja, any closing remarks?
Well, I'm just grateful to be part of this discussion, and look forward to many more of this. As Boniface says, we've lots of data that needs to be shared and out there. Part of it, of course, are used for teaching, but I'm sure there's quite a bit that can be used to improve health services. So thank you for this.
Great, thank you. Thank you, Professor, for joining us. Katherine?
I just want to say thank you for the opportunity to present our work, and thank you to all the participants. And I will echo what Boniface said. We have a lot of data. We did a lot of work, and we are happy to share that.
Great, thank you. Thank you very much. I don't see any other questions coming in, but if they do come in, I'm happy to share them with our presenters for the day via email and relay the answers back. In closing, this is just to thank our presenters for the day. Thank you, Boniface, Professor Olenja, and Katherine, and also thank you to our participants for the day. Thank you.
Thank you. Thank you, and bye.
Thank you.
Great. Thank you, everyone. Bye.